lung transplantation. We now with Professor Ayman Farghaly. بروفيسور أيمن عطاء بلا حدود، أستاذ بمعنى الكلمة، وهو حاليا بيساعدنا في طنطا في بداية وحدة جديدة عن البلمونري هايبرتنشن. وأنا عارفة إن إحنا تعبينه معانا يعني، بس هو أكيد يعني هو ما بيبخلش علينا بأي حاجة.
العفو.
Management of Sarcoidosis in Geritrics.
بسم الله الرحمن الرحيم. أشكرك دكتورة هدى على المقدمة، وبشكر التشيرز. دكتور إبراهيم، متشكرين على دايما بتجمعنا في مواضيع لطيفة وشيقة وفيري انترستنج، وبتعمل لنا ستيميليشن علشان نجدد معلوماتنا كمان. أنا أتمنى بس يعني مش قادر أسكت الحقيقة، يعني بعد ما الدكتور ياسر has raised the point of lung transplantation، أنا أتمنى أن الموضوع يبقى cadaveric. Sarcoidosis in the elderly. Actually, sarcoidosis is defined as a chronic granulomatous disorder. It is a multi-organ involvement disease. First case was described by Hutchinson, maybe 200 years or more ago. The epidemiology is widespread, and actually it is variable. The highest incidence زي ما احنا شايفين North Europe, Irish, African, I think ان احنا عندنا دلوقتي surge of sarcoidosis. انا شخصيا يعني كل اسبوع عندي 5-6 حالات sarcoidosis، خاصة ان احنا مشخصهم بالايبوس nowadays. فانا I think ان احنا عندنا surge، وبدأت ERS تقول ان هو by model age، وده احنا كلنا عارفين انه دايما يجي اليونج ليديز مش عارف ايه لكن يبدو ان احنا we need to phenotype these patients، ان ممكن يبقى فيه يونج ويبقى فيه adults، وممكن يبقوا مختلفين في البرزنتيشن. and we still have a challenge in diagnosis of sarcoidosis sometimes, especially in the elderly. The diagnosis and actually the awareness the disease is not enough. ممكن you can miss the diagnosis. طبعا الهول mark in pathophysiology is the granuloma, and I need to be very careful when I touch the granuloma. Granuloma is a non-specific diagnosis. You need to correlate clinically and biochemically in order to diagnose the case properly. Of course, with the ACE, lymphopenia, and delayed hypersensitivity reaction. Usually the patient has lymphopenia but increased lymphocytes at sites of involvement, especially T lymphocytes. It's a kind of hypersensitivity phenomena. Actually, ERS lately has practiced some guidelines on the treatment, and actually they differentiate between cardiac, skin, and other types of sarcoidosis. And for the first time, they have put the age above 50 as a risk factor, and can influence the prognosis. This is the journey of the patient. So the first is symptoms, and actually symptoms are diverse, and many of you know that we get cases of sarcoidosis from other specialties. The ophthalmologists they bring me some patients, the rheumatologists, and so on. Diagnosis, actually, we need the biopsy, and the granuloma is not the end of the diagnosis. You have to correlate clinically and biochemically. Treatment, actually, it's not different from adults and elderly and young adults. Anyhow, the type of sarcoidosis sometimes affects the choice of treatment, and follow-up and care actually is very important. And let me say that most of the cases of sarcoidosis that come in young adults does not need treatment. The practice of giving steroids for all patients is not right. So you have to weigh things and see and follow up the patient to know if the patient needs really treatment and he has endangering organs or not. Actually, when I have a patient of sarcoidosis, after diagnosis, I look for the hypercalciuria, I look for the echo and the ECG, I look for the eye if there is posterior changes in the eye. If nothing, follow up. Then I do pulmonary function after 3 months and look for this patient. Of course, the presentation and is different and variable. Fever, hilar nodes, erythema nodosum, arthralgia, and many of them are asymptomatic. and usually this is not the case in the elderly. So asymptomatic elderly usually is not the case, as I'm going to show you the numbers. Radiology, most of the cases are type 1 and 2, and other investigations can be done. And now what's have been standardized for diagnosis actually is the EBUS, transbronchial needle aspiration, and you can join it with transbronchial lung biopsy using the cryobiopsy also. So this is the stations that we go on for the EBUS, and actually for the elderly it is one of the best ways because it is less invasive than the transbronchial lung biopsy and carries almost no hazards and can be done under local anesthesia or sedation and so on. Management, actually, the recommendation from the ERS, we start with the oral steroids, and still steroids, when indicated, is the first choice. Then we have second lines like the methotrexate, azathioprine, mycophenolate. We have third agent, which is biologics, and biologics has now some role in treatment of sarcoidosis. And lastly, lung transplantation, Dr. Yasser was talking about. So this slide is very important. Only treat sarcoidosis to avoid danger. So patient who having, for example, conduction problem in the heart, and to improve quality of life. For a patient who has declining lung function, for example. So otherwise, most of the cases, they don't need treatment. This is the extra pulmonary manifestations. Again, and the hypercalcemia and the calciuria are very important, and one of the misleading presentations that come with sarcoidosis. So what is the problem with the elderly? Actually, when I look for the literature about elderly sarcoidosis, it's very sparse, very few. And these are some case presentations about sarcoidosis and its atypical presentation in the elderly, and most of the people tend to say that in the elderly it is a kind of another phenotype. So this is a case of 75 years old female. She came complaining of fatigue. Fatigue is a hallmark with loss of weight, confusion, acute and chronic renal failure, hypercalcemia, and elevated ACE. The X-ray is not that much going towards sarcoidosis. However, we could elicit some small lymph nodes, which is not bilateral and symmetrical as we see in young cases. So it is atypical in presentation, and the hallmark is fatigue. Again, this is another case have been presented: fatigue, generalized weakness, cough, poor appetite, hypercalcemia, ACE is high. CT-guided biopsy was taken on the assumption that we have masses in the lung, and actually we get the granuloma, non-caseating granuloma, and when correlated with the clinical presentation of the patient and biomarkers, for example, LDH, beta-2 microglobulin negative, and so on, this patient proved to be sarcoidosis, and we started steroids. So late onset sarcoidosis, then we tried to see what other people has gathered regarding the information. This is actually a very interesting meta-analysis, and have been carried retrospectively on patients from 2002 to 2006 in the French hospital. And as you see here, females are predominant more than males. Then we have athenia as the main factor in presentation, skin lesion other than erythema nodosum. Erythema nodosum almost is not there in elderly. However, the other bizarre skin manifestations are there, and we have other specific lesions like lupus pernio and skin nodules and so on. Uveitis actually has more prevalence in elderly, and the asymptomatic variety is almost very nil in the elderly. So elderly with sarcoidosis usually come with symptoms. Regarding the extra pulmonary the chest X-ray in stage 0 actually is more in sarcoidosis, as the case I showed to you. So most of these patients do not have widespread and clear evidence of sarcoidosis. I have a case I can remember. She came presenting with HOCM, cardiac sarcoidosis. And actually, they were going to do an operation in Aswan Center. And this case, when it was sent to us, actually for investigation, we have a multi-slice CT. We could detect lymph nodes. And when we took the biopsy, it proved to be sarcoidosis. And the patient improved on steroids. So we need to be very acquainted with the atypical presentation of sarcoidosis in childhood. In the elderly. So of course the adverse events are more common, and this is very logical with the comorbidities we encounter with the elderly. Another very important, and it is a 42 years single center experience. It is Spanish, in a Spanish center, and they got retrospective data over 42 years, so it was very representative, and they found the proportion of patients with sarcoidosis in the elderly above 65 was 7%. Löfgren syndrome actually was very infrequent, which is a kind of benign presentation. Extrapulmonary involvement and severe radiographic changes was actually prevalent, and also there is less frequency for remission. So it seems that sarcoidosis in elderly is a serious disease that needs really treatment. In the area, actually, we have a short and small-sized retrospective study in Tunisia, and actually they found almost the same manifestation, and the lab here was very impressive of hypercalcemia, renal manifestation, and the hypercalciuria, and the ACE enzyme was also elevated. So what is in the elderly sarcoidosis can help us to suspect the disease and start treatment early? It is, the incidence is variable up till now due to the sparse information. It is 7 to 30% of the cases. So different disease and diagnostic features compared to younger are there. So atypical pulmonary, atypical skin, uveitis, and the hypercalcemia are the most common presentations. Female predominance still, and the general symptoms and the comorbid diseases. The diagnosis and treatment might be difficult. You need to have expectation for the disease. Comorbidities have been suggested to be negatively affect the prognosis. It is a disease of bad prognosis in the elderly, and it sounds that we need to be more aggressive and start steroids early in the elderly and take in consideration, of course, the comorbidity. Thank you very much.
شكرا للاستاذ الدكتور ايمن فرغالي على الاليجنت برزنتيشن. الدكتور حسين عاوز بس يسالك سؤال.
في الساركويدوزيس ان elderly طبعا احنا بندستروي at least from 6 up to 12 months. What about side effect في الالدرلي patient؟ معظم بيبقوا diabetic hypertensive عندهم osteoporosis. فهنا we have to wait advantage versus disadvantage whether to give steroids or leave him and just give symptomatic treatment. So just to read this point please.
احنا اتفقنا دكتور حسين ان انت you have to weigh things. في الادلتس انا 80% of my patient I don't give treatment. في اليونج I don't give treatment at all. I follow up the patient after 3 months زي ما قلت بالاربع حاجات دول. After 6 months I follow him up ودي recommendation. وبعد كده after 1 year usually 80% of cases ممكن تتحسن. المشكله اللي في الالدرلي زي ما شفنا البرزنتيشن فيها severe symptoms منها الهايبركالسوريا. العيان ده هو develop renal failure. العيان ده هيبقى عنده manifestation. الاثينيا والويكنس والستيوبر مهمه جدا، وبالتالي انت محتاج تعمل assessment بس it seems ان انت هتبقى more aggressive in treatment. طبعا انا الحقيقه ما دخلش كتير في التريتمنت، ولكن ده موجود في الالجوريزم اللي عاملاه الاي ار اس. ساعات بيحطوا الهيدروكسي كلوروكين، بيكون مش alternative ولكن هو steroid sparing، وبالتالي بتقدر تقلل نسبه الاستيرويدز اللي انت بتستعملها، ولكن sometimes you have to go for the other drugs.
شكرا دكتور ايمن. شكرا.